depending on whereabouts you are in the world watching this. We've already seen we've got quite a few international people on this webinar for us tonight in the UK. So thank you so much for joining us. I'm just going to start with a few house rules before I introduce our speaker for tonight. There is a question section and we'd love for you to get engaged. We've already had one question already, which is great to see. If you don't know where the question section is, if you just have a look to your left-hand side, if you're on a laptop, you'll be able to see the question area. You just type those questions in and we can see them here in the background. If you're on a mobile phone or a tablet, you might just need to flick out of your video screen and then you'll find the question section within the main bit where you logged into, and you can ask questions and then come back into the live stream. You'll be able to hear it continuously as you write your questions. If you want to test that out, we'd love to see whereabouts you are in the world. We're really intrigued. We're pretty sure we've hit a complete global audience tonight, which is super exciting. So feel free to test out that functionality and then you can ask your questions throughout the talk. So tonight's talk is on feline heart disease, the diagnosis and management of it. Feline heart disease presents unique challenges. How significant is a murmur? When should we worry about an arrhythmia? And can we slow the disease progression? In this session, Dr. Chris Linney, RCVS and European specialist in small animal cardiology, will take the talk. He's going to provide a practical update on diagnosis, treatment, and monitoring of feline heart disease. Chris is the head of cardiology at Paragon Veterinary Referrals up in Yorkshire and brings a huge amount of experience in interventional cardiology and a passion for education, along with his work investigating heart disease in rescued moon bears with Animals Asia. Chris, I'm hoping you're going to expand slightly more on that, but it's really intriguing. So welcome, Chris, over to you. Maybe start with the moon bears would be really great.
Thank you very much for having me. Thanks, Lizzie, for the introduction. And thank you to both of us hosting this session tonight. I actually hadn't planned to talk very much about the Asiatic black bears, only to say that Animals Asia is a very good charity, a great charity that I do a lot of work with in China. Asiatic black bears, turns out that they also get heart disease as well, and they get a lot of systemic hypertension, whether it's from stress, whether it's genetic, whether it's related to diet and poor nutrition and inflammation, who knows. But that's a little like nugget, that's the tip of the iceberg with the bears. But tonight I'm here with you to talk about feline heart disease, and I'm a clinician at heart, so my approach to cases is always thinking about how do we look after these cases in practice, how do we manage these cats, and what information can really help to guide us in terms of treatment. So tonight, I'm going to take you through how we will manage cats with heart disease. The difficulty is, I think we have to remember that cats are not small dogs, despite some of these cats loving to act a little bit like dogs, fetching sticks, wearing Dalmatian outfits. Actually, we know that cats present with very different type of heart disease, and we probably have to think of them as a separate species when we consider heart disease and how we might manage that, both in the asymptomatic or preclinical phase, and then also in the symptomatic or clinical phase of the disease. So we are planning tonight to cover the main categories and classification of feline cardiomyopathy, looking at how we might diagnose and manage preclinical hypertrophic cardiomyopathy, which represents the largest group of cardiomyopathy that we see in cats. We'll talk about managing congestive heart failure, so clinical heart disease, and aortic thromboembolism. And then after that, we will then kind of spend a little bit of time of looking at, well, where are we going? What's next in the world of feline cardiomyopathy, and what's next for our patients in terms of treatment and management? So to start with, I think the big thing about cats, as we said, they aren't small dogs. They are very different in how they present. So one of the kind of the key things when we think about heart disease is cats with heart disease, whether it's be left or right-sided heart disease, are prone to developing pleural effusion. And in dogs, we typically think of that as a right-sided heart failure when we see pleural effusion. But due to the plumbing and the mechanics of the pulmonary veins and their viscosity, their wall permeability, we will see pleural effusions with left-sided heart disease. Importantly, a murmur can be present in cats when there is heart disease, and a murmur can be present in cats without heart disease. And in fact, around about up to almost 50% of cats that present with a murmur do not have underlying heart disease, and that in itself represents a challenge. We have a cat presented to us for vaccination with a heart murmur. Is this a cat that has heart disease or not? The presence of purely just a murmur doesn't completely help us to decide on that. We might need to look for other things. Is there an arrhythmia? Is there a gallop? Are there any clinical signs of significant heart disease? Is there a history of intermittent or transient lameness? Really looking at the clues that might piece together to help us to see whether a murmur is significant. Generally, with cardiomyopathies, murmurs are lower grades, sort of up to grade 4 may be reasonable with some forms of cardiomyopathy. But really loud murmurs, grade 5 or grade 6 murmurs, so the murmurs that you can appreciate as you put your hands on the patient and you can feel a thrill, those are more commonly associated with congenital heart disease. And we won't be covering congenital heart disease today. We'll be focusing on cardiomyopathy. When we think about sort of the questions that we ask clients, how is your patient, how's your animal exercising? Now that's a challenge in itself as well. You know, cats generally will spend the vast majority of the day asleep. Trying to decide whether a cat has exercise intolerance is a challenge. And often they won't show clinical signs of heart failure until they are in heart failure. So we don't sort of get a nice warning like we might do sometimes with dogs. Finally, when we think about heart disease and we think about lung sounds, because cats develop both pleural effusions and pulmonary edema, we may hear patients that don't have crackles but have significant respiratory disease but could still have heart disease. And crackles and sort of the lower airway noises, I guess we're really sort of moving away from calling that a sign of congestive heart failure. And I think we really should be focusing on, do these cats have clinical signs of dyspnea and tachypnea as being the top priorities for making that suspicion of heart disease. So recently, in the last 5 years, there's been a sort of a reclassification. Most of it's very similar to what we have already described. But on this Venn diagram here, which is taken from the ACVM consensus statement, the reference is also on the right-hand side there of the image, is that the majority of heart disease that we see is a HCM phenotype, so a hypertrophic left ventricle phenotype. It's important to see here that there is some overlap, and that sometimes represents the difficulty of trying to put a cardiomyopathy into a box. But the good news is, when we think about preclinical and clinical heart disease, often, irrespective of the cardiomyopathy, the treatment options are similar or the same. And that's especially true when we think about clinical or congestive heart failure ATE patients as well. But there can be some real overlap between end-stage heart disease and restrictive cardiomyopathy, and also between sort of end-stage heart disease and DCM. So these phenotypes can all look quite similar. Around the outside, you see sort of some of the other differentials that we need to consider, rule in, rule out, as potential triggers for a phenotype that looks like heart disease, but may not necessarily truly be heart disease. And when we define the individual categories for the cardiomyopathies, with hypertrophic cardiomyopathy, we're expecting to see left ventricular hypertrophy, and that the left ventricle is not dilated unless we're considering this as an end-stage cardiomyopathy, an end-stage HCM. Remember that wall thickness can be diffusely thickened, or it may be regional. So, for example, in the cats that develop a very loud murmur with hypertrophic cardiomyopathy, they may often have an element of outflow tract obstruction. So they have a sort of a thickening at the basal septum just as you leave the left ventricle towards the aorta. With restrictive cardiomyopathy, these are patients where the left ventricle is normal in dimension, and the wall thickness is normal as well, but they may have left atrial or right atrial, or a combination of both atria dilated. And you may appreciate sort of bridging fibrosis across the left ventricle, or a very bright endocardium as well. With DCM, dilated cardiomyopathy, that's often a condition where we're seeing left ventricular systolic dysfunction, similar to what we see in the dogs. And with this, we may see thin, poorly contractile left ventricles and atrial dilation as well. Typically is associated with nutrition. So kind of taurine deficiencies is one of the things that we really think about, although that's been remedied for the most part with commercial diets. But if you have a patient on an unusual diet, it's something to consider. And there are some breeds that are predisposed as well. So Himalayans and Abyssinians are two breeds that are predisposed to dilated cardiomyopathy. Then we have ARVC, so arrhythmogenic right ventricular cardiomyopathy. And in this condition, we see that the right atrium and the right ventricle are both dilated. There may be right ventricular systolic dysfunction and poor contractility of that right ventricle. But sometimes when we call it arrhythmogenic right ventricular cardiomyopathy, perhaps a better term is arrhythmogenic cardiomyopathy, because it can also affect the left ventricle too. And we're expecting there to be arrhythmias because of the fibrosis in the ventricular walls. And you may have signs of right-sided heart failure too. And then finally, a slight change in the consensus was an update in the name for the box where no one else fits into. So the non-specific phenotype. And these are cardiomyopathies with phenotypes that just don't tick all the boxes of the previous ones that we've mentioned. And so in this particular category, you describe the phenotype changes that you're seeing. So it may be that you sort of say that there is, a non-specific phenotype with poor systolic function, but normal left ventricular wall thickness and normal ventricular wall dimensions as well, left ventricular dimensions as well. So describing what you're seeing, and I think there's a big feel that you need to be able to box every cardiomyopathy. But as we go on and we talk through treatments, you'll see why sometimes that's not necessarily the kind of the ideal way of doing things, purely because we're often thinking about very similar treatment options for most of these cardiomyopathies. So just as a little summary there, obviously we're making our decision based on, is there any evidence of remodeling? Is it in the left ventricle in terms of wall thickness? Is it that the left atrium is dilated? Is the left ventricle dilated as well? What does the systolic function look like, and how does the right heart look? Are there any arrhythmias? Have you heard any? Do you have an ECG on the patient that you've identified some as well? It's thought that about 80% of patients that you hear an arrhythmia in are likely to have a form of underlying heart disease. So an arrhythmia in a cat is always worth investigating, because 80% of the time there is likely to be an underlying disease causing those arrhythmias in cats, which is very different to dogs. And if you're familiar with the mitral valve staging or the dilated cardiomyopathy staging for dogs, a similar approach has been adopted for feline cardiomyopathies. So it's actually really nice because when we think about the recommendations, it sort of all follows this stage A, B, C, and D. So A would be your predisposed animals with a family history of heart disease, or breeds that are prone to disease, like for example Sphinxes and Maine Coons with HCM. Our B1 patients are those patients that are in the subclinical phase. I have used the word asymptomatic, but trying to decide if a cat has symptoms is a challenge in itself. So sometimes they may be missed by the owner. Sometimes the cats might mask the signs that they're feeling. So subclinical is probably most appropriate. And in the B1 patients, these are patients that are low risk of having an adverse event, being congestive heart failure or an aortic thromboembolic event. And these patients typically will have a normal sized left atrium, or they might have some mild left atrial dilation. When we think about the B2 patients, these are patients that are still in that subclinical phase, no evidence of outward clinical signs, but they're starting to show signs of an increasingly progressive left atrial dilation. And these patients will be at higher risk of going into our clinical stages, stage C and stage D. Stage C patients are patients that have developed either an ATE, an aortic thromboembolus, or they are patients that have developed congestive heart failure. So once you hit C, even if you're well controlled and the signs go away, you would still be considered a stage C patient. And finally, our refractory patients, our stage D patients, are those that are requiring higher doses of diuretics and are becoming more refractory to treatment. So these are going to be the patients that are on over 6 milligrams per kilo per day, which is the recommendation from the consensus statement, where we might start thinking about adjusting and trying to optimize treatments further. So because feline hypertrophic cardiomyopathy is the most common one that we see, I thought I'd just spend a slide just talking through some of the statistics around it. And I think one of the most important ones is about 1 in 7 cats in the general population will have HCM in their lifetime. And I think that's important to know, because 1 in 7 of those cats that present to you in the clinic will have HCM, whether they're subclinical or whether they're clinical. And this has been shown both in the States, both in the UK. It's been shown in shelter populations and referral populations as well. But what's also important to note is as cats get older, the prevalence also increases, and that's irrespective of other systemic diseases like hypothyroidism and systemic hypertension. So up to about 30% of cats in the older age brackets may have HCM. And I guess what I put to you with this is, if we think these cats, there's quite a high incidence of HCM in the older population, if you are doing preclinical assessments of these patients for GA, including blood work, should we be assessing also that a third of them might have heart disease, and potentially because of that, we should be considering assessment of the heart before we do the GA, just as we might check the kidneys before a dental. The good news for most cats is that the majority of them will be stage B for their lifetimes, and there's only a proportion that go on to develop heart failure. And if we look at every cat that presents with heart disease, then the mortality over a 5-year rate is about 23%. And this is irrespective of the age that these patients are diagnosed. So, a quarter of cats that are diagnosed with heart disease are likely to succumb to it in a 5-year period. It's kind of information that's great to use for the clients and gives us a bit of a grounding and understanding of this condition. Remembering that there are some wolves in sheep's clothing when we think about the different diseases that may look like HCM, so our HCM phenocopies. Important that we exclude hypothyroidism. So thyroxine has a direct effect on myocardial hypertrophy, as well as other effects that will change heart rate and also reduce peripheral vascular resistance. When we think about systemic hypertension, that causes an increase in afterload, so it's harder for the heart to pump against the high pressure in the vascular system. So that increases wall stress, and the body's response to that via Laplace's law is to get left ventricular hypertrophy to reduce that wall stress. A condition called transient myocardial thickening also exists, which looks very much like HCM, but often the left ventricles aren't quite as thick as you might see with HCM. And then we have some of the more unusual causes like acromegaly, so an excess of insulin growth factor 1, causing proliferation of the left ventricle. Sorry. Hypovolemia is an important one too. So a cat that presents that's very sick, that's been vomiting, diarrhea, has had inappetence or anorexia, remember that they will have left ventricles that may look like they're hypertrophied, but if it looks like the lumen is very small, remember that poorly hydrated animals may look like HCM because they are hypovolemic. And then we have our infiltrative type diseases, of which lymphoma might be the most common, but we see a number of different infiltrations in the heart. I wanted just to mention transient myocardial thickening because although it's not a very new condition, it's a condition that we have that actually carries a much better prognosis than some of the other diseases that we see. And a study that came from a group from the RVC showed that these patients had a kind of a reversible form of hypertrophy of the left ventricle, and all of the cats that were diagnosed with this transient myocardial thickening had an excellent prognosis. They had changes on their hearts on the initial echo when they were in heart failure, and with treatment for heart failure, within about 3.5 months on average, these patients remodeled back to normal. So this is a disease where the heart looks and sounds exactly like a HCM in heart failure, but they reverse. The jury is still out as to what this actually is. Is it a form of myocarditis? Is it related to stress-induced changes that we might see in the human condition, which is called broken heart syndrome, so Takotsubo? Is it something that is it an infectious agent that we just don't know about yet? So there's a lot of interest in this condition, but it makes us think that if we have a cat that has mild left ventricular hypertrophy and is in heart failure, that perhaps this could be one of those cases of TMT. So we just sort of think about this in terms of if we're going to suggest pulling the plug, that there is a condition where it can be reversible. So maybe consideration of treatment is reasonable for congestive heart failure. I'm going to jump through this one. So in terms of echo, in terms of an ultrasound, what's important? And this is sort of taken out of the consensus statement for feline cardiomyopathy. Whether we do a focal scan, a focused scan, a standard of care scan, or a full assessment, you can see with each of these different levels of scan that we have a different amount of information that we're pulling from them. So a full assessment is what you would probably get in most referral practices with kind of a whole host of information that can help us to stratify and look at kind of the minutiae of risk factors for the patient. In the standard of care, we get enough information here to guide our treatment. We get enough information to assess the risks, some of these risk factors for patients, but probably consider it as a standard of care, but perhaps not a complete scan. And in the focus group, this is probably what we'd be considering for patients where they present with clinical signs, because if we're looking at a patient that presents with a suspicion of heart disease, a focus scan may be sufficient to say, yes, the left atrium is huge, or that there is a pleural effusion, or I can see a great big clot in the left atrium. There might be B lines in the chest consistent with potentially pulmonary edema. So we can get information that can help us guide our decision making. But if we're thinking about a subclinical case, we're probably going to need to thinking about the standard of care or the full assessment. And just to kind of look through those things in a little bit more detail, well, what is it that we're looking to assess? So on our focus scan, we're going to be thinking about the left atrial size, pleural effusion, pericardial effusion. Is there a clot? Is there a risk for a clot? Is there any evidence of heart failure? Is there any evidence of B-lines? Potentially looking for non-cardiogenic causes of dyspnea and tachypnea, so thoracic masses or a pneumothorax, and looking for other things that could give us a patient that presents like a heart failure patient. So just in terms of a few images, and this is really for a POCUS scan, we put the probe on the patient, and this is what we see. So here we have a patient that presents with a history of congestive heart failure signs, or compatible with congestive heart failure, and we put the probe on. And I guess just in terms of our chambers, we have our left atrium over here on the right hand side, we have our left ventricle over on the left hand side, and the right heart is kind of the squidged up there at the top. So first thing to say is that this left atrium is stonkingly massive, or huge, is probably a fair reflection. Severely dilated, perhaps, if you wanted to write it in a report. But whatever way you put it, this is humongous. And when I look at this left atrium, normally it should be less than about 15 millimeters. And you can see the scale in yellow on the left-hand side of the wedge. And this left atrium is well over 25 millimeters. We look at the left ventricle, and we see that the interventricular septum is doing its hardest to pump blood out of this left ventricle, but the left ventricular free wall is doing very little work at all. It's thinner, it's poorly contractile, and this would be consistent of a patient that may have developed a myocardial infarct. So there's been a lack of blood flow to that free wall, and now we have a scarred fibrotic left ventricular free wall. So this regional asynchrony is a really poor prognostic indicator as well, and these patients tend to be very difficult to control with their heart failure. But cats being cats, sometimes you see hearts like these in patients that just come in for assessment of a murmur, and you think, wow, these cats have been living with this heart disease. So cats are really challenging in that respect too. One of my tips in terms of looking for pleural effusion. So pleural effusion in a cat that comes in with dyspnea, we'll typically assess this with them in a sitting or a standing position. And if you think of the shape of the cat's chests, with gravity, that fluid is going to reach the lowest dependent part of the chest, and that typically will be at the caudal aspect of the chest. It's going to be near to the diaphragm and in front of the liver. So that's kind of where we're looking for effusions. And what we might see is the ligaments that connect the heart to the pericardium to the diaphragm. We may see fronds of tissue floating around, or we might see a collapsed consolidated lung lobe floating in the tissue, and that can help us to look for these pleural effusions. And if it's large enough that you can kind of see the depth here is about 4 centimeters, we're always going to probably look at trying to drain this if the cat has clinical signs of tachypnea and dyspnea, because that will help to alleviate these signs. The tricky thing that we have is if it's only a small volume, we might need to say, well, is it sufficient to be causing clinical signs of heart failure? But tapping this fluid will also provide relief and potentially can be used for cytology if we don't think it's related to the heart itself. And finally, we think about the risk of thromboembolic disease. So this is a cat that presented for a dental, and the vets detected a murmur, and the owners wanted to go for a referral assessment before the dental. And this is what we see. So this, again, we have the left atrium is this large structure just on like basically monopolizing the screen. And we have our left ventricle just over between the 2 and the 4 centimeter marker. In this left atrium, we have a mobile thrombus that almost looks like a fried egg, and we have a clot sat in the left auricle here as well, with a little bit of pericardial effusion highlighting the tip of the auricle here too. So these are the kind of all things that we're looking for in our POCUS scan, and in doing this, we can kind of stratify the risk of our patients and the necessity for therapy. If we then move on to looking for B-lines, now I think I know in my clinical practice that I now do a lung ultrasound much sooner than I would do a chest radiograph in a dyspneic patient, partly because it's available, it's ready available, it's in our ER room, and also that I can have enough information from my cardiac assessment and the lung assessment to decide whether or not we should be trialing this patient on heart failure medications. So if the left atrium is dilated and we are seeing changes in the lungs based on seeing a number of B-lines, and the patient has clinical signs of being tachypnic and dyspneic, I'm going to give this patient a dose of frusemide before considering radiographs. If there's anything unusual about the history or what we see on the scan, or the left atrium is normal, I may be considering whether we need radiographs to understand what's going on. But you're never going to harm a patient with a one-off dose of furosemide. If you suspect that they're in heart failure, it's going to alleviate some of their clinical signs. And what we're looking at here is we see a bright white interface, which is the A line, the surface of the pleura. And if there's fluid or infiltrate of cells in that lung, it's going to allow the artifacts to ring down through the image. And you see these very bright striations that make it from the near field all the way down to the far field. And these are the B lines. So they're sometimes called rockets or comet tails, and they represent either fluid or cellular infiltrates. So we will see these with cardiogenic edema. We'll see them with non-cardiogenic edema. We'll also see these with pneumonia, with hemorrhage, and with neoplasia. So when we see them, it tells us that there is lung pathology. It does not tell us that the patient is in heart failure, but we couple together our physical findings, our focus scan of the heart, and what we see within the lung assessment, and we put that all together to give us a best guess of whether the patient may or may not be in heart failure. Almost 100% of cats will either in congestive heart failure will have B lines or pleural effusion or a combination of both. When we think about left atrial size, important to remember that left atrial size should be assessed from both the long axis view and the short axis view. And when we looked at it from the long axis view on our previous images, we assessed it on the top left and the top left and bottom right hand image to look at the long axis view. And normally, when we think about that size of the left atrium, this left atrium should be less than 15 millimeters in diameter. And if it starts to get bigger than that, we start to then go through the classification of, is it mildly dilated or moderately dilated? And then that in itself then makes us decide whether or not we might start to think about treatment. From the short axis view, where we take the left atrium to aorta ratio, on this view, the ratio here should be less than 1.5. So your left atrium should be no more than 1.5 times the size of your aorta. And in using this information, we can then make a decision about risk of heart failure, potential benefit from being on antithrombotics. Finally, just as another just to get your eye in on some cardiomyopathies, these are 4 cases of different types of heart disease. So we have on the top left, we have a case of hypertrophic cardiomyopathy. And hopefully on your screens, you can see a small amount of spontaneous echo contrast just wisping its way through the mitral valve, just as a little bit of spontaneous echo contrast on this image. Down the bottom left is a patient, this is a 14-year-old Abyssinian, and this is what we might expect to see with dilated cardiomyopathy. But we may also see this form of change in cases of like an end-stage dilated end-stage HCM as well. Although in this particular instance, the left atrium is of a relatively normal size, but that right atrium almost looks bigger than the left atrium. So this kind of has a little bit of an odd-looking phenotype. On the top right image, we see a patient that has a dilated right ventricle and what looks like a dilated right atrium, although I appreciate that we don't see it very well on the screen. And this was a young Burman who was diagnosed with arrhythmogenic right ventricular cardiomyopathy in the end on post-mortem. So having kind of got our eye in on what we're going to look for in terms of making a diagnosis, we're now going to move on to the treatment strategies and how are we going to manage these patients, breaking it down into our preclinical and our clinical cases. So our stage B1, remember, are our patients that have subclinical disease and they have low risk of an adverse event, congestive heart failure or a thromboembolic event. And so for the vast majority, there is no treatment recommendation. There is no medications recommended at this stage at this time. Beta blockade is sometimes considered, so beta blockers for an outflow tract obstruction form of HCM is something that is considered from time to time, but with a caveat. And so the caveat is, should we consider beta blockers for cats with an outflow tract obstruction? We know that in previous studies, it's been shown that giving atenolol decreases the heart rate and it decreases the murmur grade. So we reduce the degree of outflow tract obstruction, and it's that's causing the murmur in these patients. But what we also need to understand is reducing the murmur grade and decreasing the heart rate improving outcome? So it's all well and good that we change things that we can hear, makes us feel better, but what's it doing for the patient? And actually, on a 5-year all-cause mortality study, there was no difference in patients that had received atenolol versus not been on atenolol. So this really kind of shook the world in terms of managing cats with outflow tract obstructions. And my preference now is to avoid beta blockers unless there's some specific criteria. So cases that perhaps have a severe form of outflow tract obstruction, or patients that have evidence of exercise intolerance, which we've said already is a really challenging thing to do. But there are certainly cats that will become very breathless, potentially show signs of pain like hypersalivation, immobile, crying out, but not really wanting to move. And these are all things that can be seen in humans that have outflow tract obstruction associated with HCM. And so in humans, it's been shown to improve exertional dyspnea. And I do believe there is a subset of cats that would benefit from medications, as particularly if they're showing clinical signs. The important thing when we're thinking about beta blockers, though, is it's really important that cats continue on beta blockers. So if the owners can consistently medicate the cats, then it's definitely a consideration. But when we give a beta blocker, we are blocking the beta receptors around the heart. And what the body will do in response to that is it will make more beta receptors. So if we then miss a day or two beta blockers, and then we have all these beta receptors sat there ready, waiting to receive a beta adrenergic stimulation, we will see an increase in contractility, we'll see an increase in heart rate, we'll see that these cats, that might be enough for these cats to then have an adverse event from all of these catechloramines and changes that undergo the heart because of all these new receptors that have come there due to the beta blockers. So really important if a cat's on beta blockers that they don't get stopped suddenly and that they can be given consistently. If we move on to our stage B2 patients, these are the ones where we have a higher risk of an adverse event. So they're at higher risk of a thromboembolic event or developing congestive heart failure. And so what puts them at this risk? Well, the first thing is that the left atrium is dilated. But more than that, if we think about what other things that we need to consider is their left atrial function reduced? So if the left atrium function is not great, we might see spontaneous echocontrast. We might see that the actual kind of fractional shortening, so kind of the difference between the maximal and minimal size of that left atrium is reduced. And we might see that the flow in and out of the left auricle is also reduced as well. And all of these things build a picture to make us decide, should we be thinking about starting medications to reduce the risk of a thromboembolic event? And on the right here, you see Virchow's triad, which is that we need to have an element of all three of these to see a patient go on to get, to get a thrombus. And a number of these are present in our cats that develop an ATE. So what about clopidogrel? Well, the first thing to say is that clopidogrel has been our long-term treatment for quite some time. It sort of overtook aspirin back in kind of the last decade when we think about the fat cat study. But clopidogrel will inhibit platelet aggregation and it deactivates those platelets that are there. So the platelets that you produce that have had clopidogrel acting on them will no longer be functional. They reduce aggregation of platelets, they reduce fibrinogen, and they prevent the expression of tissue factor on the endothelial cells so that you get less sticking together of red cells against a surface. What's important to say is actually in humans, there is a polymorphism in the gene where clopidogrel attaches to. And if you have this polymorphism, in humans, 5 to 30% of humans are not able to metabolize clopidogrel to the active ingredient, and it's ineffective. And I think that's important to remember for our cats as well. And it has been shown that cats can also have this polymorphism and they may be less able to get the benefit from being on clopidogrel. In the fat cat study, this is a study that was looking at the use of clopidogrel versus aspirin. These patients were included in the study. What's important to mention with this is that you look at the groups here, that the group that were on aspirin had a kind of a median survival time of 128 days. The group that were on clopidogrel had a median survival time of 346. There's obviously a clear difference here. But these are all cats that were included 1 to 3 months after having had their first thromboembolic event. So they got through the acute phase. They were in a little bit more of a happy, stable place before they were enrolled. And so those numbers are not really reflective of general practice in that a lot of the time, what we haven't got in this group of patients are the ones that come in that are in a huge amount of pain. And so I think it gives this sort of slightly rose-tinted assessment to think on face value, oh, look, a cat that goes into clopidogrel could live for a year. But this is a cat that's managed to get through the acute phase of a thrombus. And so what we do is we look at that, which is a stage C patient, if they developed an AT already, and we extrapolate that to stage B2 to think, well, if it may have a benefit of preventing a secondary clot forming, it may also have a benefit of reducing the chance of a primary clot forming. And so that's how its use has become used in stage B2. we think about stage B2 and moving into kind of now the late sort of last decade and this decade. Actually, another drug that's sort of gained a lot of popularity is the factor 10A inhibitors. So apixaban, rivaroxaban, any of the bans really. But rivaroxaban has gained a lot of popularity in its use. And we have the data now from the SuperCat study, which compared the use of clopidogrel against rivaroxaban. And again, this was to prevent a secondary thrombus event. So these are patients that had already had a primary thrombus and were trying to prevent a secondary thrombus or a second event thrombus. And in this study, around about 40% of cases had a recurrence of thrombus within the study time. And I guess that's important because of the implications it has on the patient and patient welfare. When we look at the actual time to an event, the times here again are very long. So median time to cardiac death or an ATE was almost 2 years in the clopidogrel group versus 513 days in the rivaroxaban group. And whilst there's a slight difference in those numbers, overall, what the conclusion is that actually you could use rivaroxaban or you could use clopidogrel as a prevention of a second event of a thrombus. But how about both of them together? So yes, clopidogrel has its benefits. Yes, rivaroxaban has been shown to be just as beneficial. But there aren't any prospective studies looking at the two together yet. But there is a retrospective assessment that comes from this paper where they both were used together. And I guess what was shown in this paper is that potentially there are adverse side effects. So 15% of cats developed an adverse event, and that was typically hemorrhage. The hemorrhage was self-limiting and didn't require blood transfusion, which I guess is a good thing in its own right. But these cats might have had nasal hemorrhage or epistaxis. They may have had hematemesis or hematochezia or melena. So important to say that, that's not benign, although they didn't need a blood transfusion. None of those things are benign. We will consider the use of both drugs together, but we make the client aware that there is an increased risk of bleeding. And if we have a patient that we see that's been on clopidogrel and we see evidence of a thrombus, we may then add in rivaroxaban and use dual therapy in that situation. So what other things can we do for these B2 patients? Well, aspirin probably is no longer a treatment of choice when we look at the fat cat study, but maybe could be used if the cats don't tolerate the other agents or they're unavailable. Clopidogrel is very bitter, and some cats may take a dislike to it and not be able to be medicated. There is oral forms, but there are also liquid forms as well. So there are 2 types to try. With rivaroxaban, again, if you use the smaller size tablets and you use the 2.5 milligram tablets, they have a film on the outside, so cats may be better medicated with that. But important to remember that all of this is a kind of a medication burden on the owners, but also the cat. Low molecular weight heparin hasn't really been shown in the stage B2 cats. Injecting a cat 2 or 3 times a day in a preclinical, subclinical phase is very difficult to justify, particularly with the absence of evidence. So it's not something that I'd be recommending. And finally, if we think about ACE inhibition, there's no evidence that ACE inhibition in this preclinical phase is beneficial. It hasn't been shown to reduce left ventricular wall mass. It hasn't been shown to improve function of the heart. And it hasn't been shown to delay the onset to heart failure in those subclinical, preclinical cats. Pimabendin doesn't have any good evidence in this preclinical phase either. And if there are arrhythmias, which is pretty rare in the stage B2 patients, if there's significant ventricular ectopy, we may consider treatment. But in my experience, most cats that have cardiomyopathy and they have significant arrhythmias have structural changes in their hearts as well. So we'll move to the kind of the stage C, stage D cardiomyopathies, so our clinical cases, and just spend a little bit of time of thinking, well, what do we do in those acute settings? And I guess the key is furosemide or a loop diuretic. In the UK, we only have an injectable form of furosemide. So we use that as an IV preparation, as an intramuscular preparation, and both of those modes of actions are relatively quick. Furosemide does have a fairly neutral pH, so cats don't have much discomfort to injections into the muscle with furosemide. Intravenous has a slightly faster action, so we will try to give it intravenously if we don't stress the cat trying to replace an IV. But typically, my first dose in a very dyspneic cat might be intramuscular with some oxygen therapy, potentially a little bit of sedation. Cats like this are on a very tight knife edge, and we don't want to stress them to the point that they have a respiratory embarrassment and an arrest. chest. So we try and handle them with kid gloves on, so that they hopefully won't have any major complications. We'll come on to sedation, but I don't have any issue with sedating cats in heart failure, but it's important to know what drugs we're using and those effects of those drugs on the heart and on the respiratory system. Try to keep the environment low stress. If you can control the temperature and the humidity, that makes a massive difference for these cats. If we keep them in a warm, humid oxygen kennel, they will invariably start to become tachypnic because of the humidity and the heat. And it can then be very difficult to decide, are they improving? Or if they're not improving, is it because of the environment versus is it because the drugs aren't working? And really importantly, if there is a pleural effusion, drain the pleural effusion if it's of a significant volume. The number of cats that I see that come into the clinic and we drain their pleural effusion, and they do have B-lines, they have pulmonary edema, but you reduce the volume of pleural effusion, the lungs can expand, and yes, there is edema in them, but they have more room to expand, and the cat's respiratory rate and effort drops dramatically. So really important to kind of factor that in, because the pleural effusion will only kind of go very slowly if we rely on the loop diuretics. Better to evacuate the chest. If there's poor cardiac output signs, so if these patients are hypotensive, if they have hypothermia or they're bradycardic, consider the use of positive inotropes like pimabendin, assuming there is no outflow tract obstruction, although there is some evidence to suggest that even in the presence of an outflow tract obstruction, you may be able to consider its use. If that's not working, you may in your ER setting consider a constant rate infusion of dobutamine. In some centres, they may use nitroglycerine patches or ointment. Anecdotally, I've seen in a number of places that this is something that is done, and it's a venodilator, so it kind of reduces the preload on the heart, a little bit like furosemide is also a preload reducer, but no great evidence for its use. And if these cats are having lots of furosemide, we don't add in ACE inhibitors because it may worsen renal flow. And the mainstay is going to be our diuretics. So typically we're reaching for furosemide in the emergency setting just because we have a parenteral version of it. But torazamide is a good consideration for managing more chronic heart failure. In the UK, we only have an oral version of torazamide. There may be better bioavailability in the torazamide group. In cats and dogs, well, particularly dogs, the bioavailability of furosemide is very variable, anywhere from about 40% up to about 60 to 70%, whereas the bioavailability of torazamide is about 90%. But even though we say that it's more bioavailable, it's really about how that drug is absorbed and how the kidneys are able to use that drug. But potentially, if you can get more to the kidneys, you may get a better response if those kidneys are receptive to the loop diuretic. Torazamide might also reduce tablet burden and frequency. So we might be able to get the dose down to once a day or twice a day with the diuretics, when it may be with furosemide that we're giving that 3, sometimes 4 times daily. And it has been shown to sort of be a useful treatment for managing heart disease in cats. So, we do use torazamide, typically not as first line in my centre, but it is something that can be used as first line treatment. When we consider ACE inhibitors, I mentioned that we don't recommend these in stage B2, but actually the evidence for their use in stage C is also limited as well. So in this particular study, they showed no benefit of using ACE inhibitors to delay the onset of heart failure. And actually, there was no evidence in these cats that were in heart failure that there was any reduction in left atrial size or wall thickness or quality of life. With our spironolactone, just thinking about the RAS pathway, spironolactone, and you can see here on this Kaplan-Meier survival curve, is that it may be that cats that are administered spironolactone may have a better outcome. There are some issues with the groups in this study, in that the cats that were on spironolactone had smaller left atria at the beginning of this study than the cats that were not on spironolactone, and so that there may be some biases in this study, but certainly safe, tolerated, and no major adverse side effects. You may have heard spironolactone can cause facial pruritus and has been shown in a colony of Maine Coons, but so far only in the Maine Coons, not necessarily reported on a widespread basis. So what else might we consider with managing heart failure? Well, first off is to discuss diet history. There are a number of diets where they may have home cooked diets, they may are human diets, or they may be on vegan diets. So really important to remember that if they are on a home cooked diet, that we need to remember that taurine may be low, and supplementation with taurine. So usually we use 250 milligrams twice a day would be recommended. Look for cardiac cachexia. Cardiac cachexia is gives a negative outlook in heart failure, but can also show that a patient has poorly controlled heart disease as well. And finally, if the potassium is low, remember that potassium is really important for all intracellular mechanisms. And if it's low, it will also be low in the cardiomyocytes. So we will supplement potassium if it's lower than the reference interval, and it can affect appetite. So these cats might be anorexic because they have low potassium levels. So we will always try to correct that. Finally, just sort of talking through a couple of other drugs. So pimabendin, it's well tolerated. Cats take it very well. But actually, in this study that was published in 2021, there was no survival benefit at 6 months into the study. So cats that went on to pimabendin didn't have a survival benefit. Now, what I would take from this is that if we think of the great big population of cats, there was no survival advantage. But if we think about these cats that maybe present with end-stage HCM, poor left ventricular function, poor left atrial function, it has been shown that pimabendin can improve left atrial function, and we know that pimabendin will improve left ventricular function. So I think probably what we need to think about in these patients is pimabendin may be beneficial in some patients, but as a whole with HCM, there are studies that don't support its use. So just in terms of justifying medications for clients. And when it comes to ATE, managing an aortic thromboembolic event, key here is that these patients can be painful, really painful. So really important to get the opioids pain relief on board as soon as you can. We will start them on loading doses of clopidogrel if they've not already been on clopidogrel. So we will give them a 75 milligram loading dose of clopidogrel on day 1. And we may also consider other drugs to go alongside that. So oral 10A inhibitors like rivaroxaban, and you can consider low molecular weight heparin. We don't generally do that in our clinic, but it is a consideration. Now, what about thrombolytic therapy? So trying to get rid of the clot in situ. Well, BLAST, this is a great acronym. So BLAST, bilateral lysis of aortic thrombuses with tissue plasminogen activator. So the BLAST study showed that there was no statistically significant effect on survival at 48 hours. So cats that had thrombolysis didn't do better at the 48-hour mark. That actually survival to discharge rates were about 30 to 45%. And that actually when we give these drugs, there are complications of renal injury and reperfusion injury. So generally, we don't do thrombolysis. We don't do thrombectomy. It's very rare that's actually done in the UK, because actually once you have a thrombus, it's the secondary effects of the thrombus. So vasoconstriction that is the problem, not the clot itself. It's all the inflammation and inflammatory mediators that are released and vasoconstrictive agents that are released afterwards. And don't forget, when you have an ATE, about 50% of cats that present with an ATE will be in heart failure. So don't assume that the pain is causing tachypnea. Don't assume that tachypnea is because of pain. Make sure that you've assessed for congestive heart failure as well. I did mention that I talk about sedation. So gabapentin and trazodone are 2 drugs that we would use in patients to try and help to calm them both before coming to the hospital, if they are patients that we're reviewing on a regular basis, but also if they're in the hospital and they need to stay for a little while. These are 2 drugs that we would use in our hospitals with cats. Only time that we're slightly cautious with trazodone is if they have ventricular arrhythmias already. There is some links potentially to arrhythmias in cats. Arrhythmias in people, and we worry about that with cats. And gabapentin, if there is poor renal perfusion, reduce the dose because this is a renally excreted drug. So they will have higher levels in their blood system if they have renal insufficiency. Butorphanol is a drug that I use very commonly for many of my anxious or fractious cats, and I'm quite happy to go to 0.3 to 0.4 milligrams per kilo as an IV or an IM injection. Ace-promazine sometimes is considered, but I feel that is something that you should use very carefully in hypotensive cats. So if you haven't checked blood pressure, it's not a drug that I would give to a cat without checking blood pressure first. So I'm just going to spend these last 2 minutes just talking through the next decade. So where are we going and where are we at the moment? So there has been a flurry of information both in the human world and in the canine world and now in the feline world about the use of rapamycin. And rapamycin works on the mTOR pathway. So the rapamycin pathway. So this is a target pathway for rapamycin. And this particular pathway eventually causes hypertrophy of the myocardium. So if we are able to reverse that and we're able to act on the mTOR, then we will reduce left ventricular hypertrophy or slow it down. And so RapaCat was a trial that initially looked at a small group of cats, 43 cats with subclinical HCM, and showed that it prevented or delayed progression of left ventricular hypertrophy. Now, there are ongoing trials both in the States and around the world using rapamycin. And currently in the UK, we don't have access to the drug. And I guess we are waiting to see that the data shows that reducing left ventricular hypertrophy provides a long-term solution for these cats. There's no point in these cats having medications if there's no survival advantage. So that's kind of the real key of information. But this is really promising, though, that left ventricular hypertrophy will reduce on these medications. There are other drugs around the world as well. So we have mavacamten and aficamten, and both of these will inhibit myosin in the cardiomyocytes. So that's sort of the part that becomes hypertrophied. And so we see that these cats, when they go onto these drugs, will have less systolic function, less left ventricular outflow tract obstruction, and this may also be another route of treatment. So early days for these drugs, really exciting for these two drugs as well, but not drugs that we have a huge amount of experience of in the UK. But I'd be really interested to hear people's thoughts on this as well, and what they're doing in your own, what you're doing in your own countries as well. But still kind of waiting for the real solid data about sort of prospective clinical trials in clinical patients and subclinical patients. So just to summarize, when we think about therapy, so our stage A are at risk, no therapy required. Our stage B1 are those ones where we will consider doing nothing, or we may consider atenolol if they have a severe outflow tract obstruction. Our B2 patients, we are going to recommend antithrombotic therapy, and that could be clopidogrel, but equally could be rivaroxaban as your first line, based on the SuperCat study. As the risk increases in that stage B2, so if they've got poor atrial function, if you see a clot, we may consider the combination of both drugs together. In our stage C dogs, remember that we don't just treat congestive heart failure when it's pulmonary edema. We need to remember about pleural effusions and treating both. And that we should consider an antithrombotic alongside RAS suppression, potentially spironolactone. But the other two drugs perhaps have less of a part to play, but they are sort of equally available to use in stage C. And in stage D, we're looking at using all the drugs that we use in stage C, but we will be using higher doses, so more than 6 mg per kilo of furosemide, or needing to switch them over to torazamide. And don't forget the other extra little bit. So think about the taurine, think about the potassium in these patients as well. So hopefully that kind of brings together the theory, the types of cardiomyopathy, the challenges that we have in diagnosis and the kind of things to look out for with the diagnosis, how to pick out a stage B1 versus a stage B2 patient, how we kind of look for congestive heart failure in the cats when we're thinking about echo. And you'll notice I haven't talked about radiographs because I think a lot of what we decide in an ER setting can be decided on first line with ultrasound. And I think then if those patients don't respond as we expect, then we may well consider to go on and do further diagnostics. So thank you very much for listening. I'm very happy to take any questions that we have. And I'm just going to turn my camera off just now and join you in the room. So.
Hey, Chris. That was
Hello.
great.
Hopefully that's
really
worked.
good questions come through. I've been tracking them, and we've had a
Great.
huge amount of people join us tonight, which is fantastic. The furthest one from the UK was definitely New Zealand. So,
oh well, hello,
yeah.
New Zealand.
Well done to the Southern Hemisphere who's joined us at a really early hour, and well done to everybody here who is, now getting quite late at night for the UK people in the Northern Hemisphere. So, thank you, everybody. We'll move on to some really good questions. I'm going to start. Obviously, the questions are coming through as the presentations work through, so we might be going back over some of the bits that we've already discussed, but I thought we'd start off with a nice, simple question for you. What are the breeds of DCM? Is it mainly Himalayan and the Maine Coons?
So I think kind of in the studies, Abyssinians and Himalayans tend to be the most common. Maine Coon's a slight challenge in just to remember that Venn diagram. Of the different types of cardiomyopathy, I think sometimes the end stage feline HCM can look like a DCM phenotype. So I think there is some overlap there. But those would probably be the two breeds that I'd be thinking if I saw those breeds. Then I would be considering, could this be primary? But also then thinking, diet history is so important as well. And would they be on a diet that might be low in taurine?
Brilliant, thank you. Next question. How frequently would you recommend restaging patients who have already shown evidence of mild atrial enlargement in the absence of any change in symptoms?
Yeah, that's a great question. And I think when we think about what treatment options are available, there's a couple of thoughts there. So if they are a stage B1, if they're early HCM and we haven't started treatment, then we probably do want to monitor those patients over time. And so if they're a stage one, usually the recommendation is to monitor those patients potentially on a yearly basis, is what's recommended in the ACVM consensus statement. But it may also be based on if you've seen the patient more than once, if you start to see more rapid progression, you may reduce that time interval. Once the patients are stage B2, so once they are already on clopidogrel, the question then comes is there any value in repeating assessments on these patients when we know that one of the triggers that can cause them to progress into congestive heart failure is a stressful event, i.e. potentially a trip to the vets to have an assessment. So that's really important to balance with that if these cats do have progressive signs of left atrial dilation in their stage B2, that we may want to think about adding in an additional antithrombotic. So there is some value of reviewing these cats that are stage B2 because it may change what we do in terms of adding extra drugs in. And I think once they're stage B2, I will often review these patients perhaps every 6 months with the view that we may add in an additional antithrombotic. But the evidence base for that is very weak. So I kind of put my hand up to say that is my preference, knowing kind of how catastrophic an aortic thromboembolic event can be. If there are medications that may help to reduce that risk, then we would add them in. Equally, you could say, well, why not just do both two like dual therapy for antithrombotic disease and put them both on clopidogrel and rivaroxaban at stage B1. I think that would also be a good thing to consider. But remember that 1 in 7 cats may develop an adverse event. Also remember that that's 2 medications that the owner has to medicate the cat on for the rest of its life. And it may be that it's a very slowly progressive condition where it's a very slow transition from stage B1 to B2. Or it might be it might be that they stay in stage B2 for a long time. So my preference is often to monitor, and that sort of changes dependent on whether they're stage B1 or B2. I hope that answers that question. But yeah, great question.
Brilliant, thank you. Older cats for general anaesthetic, cardio check, like checking kidneys. Are you referring to checking the pro BNP?
So actually, no, I think that there is definitely, when we think about a screening test, we have to consider the population that a screening test is being used in. So I guess just to kind of take it back a little step. So NT-proBNP is a great test for looking to say it's a screening tool. So for us, it's a test to say what's the likelihood of a patient having heart disease? And when you think about likelihood, it's then important to think about the prevalence of a condition. So in the general population, say, for example, an animal that comes in that doesn't have any evidence of heart disease, there's no murmur, there's no gallop, there's no arrhythmia, there's no outward signs of heart disease, that it may be that test doesn't have as good value as in it might have in a dyspneic patient that comes in with a very fast respiratory rate and maybe a gallop. And then the NT-proBNP comes into its own in terms of having a much higher sensitivity and specificity. So for me, I'd actually consider that a fast scan is probably more appropriate in that pre-GA assessment than an NT-proBNP, both in terms of that it's non-invasive, but also that it gives you a lot of information. Is there any evidence of B1 disease? Is there a big left atrium? A bit like the video I showed you of the cat that came in for a pre-dental assessment with that great big left atrium. Should we hang fire with doing a GA on a cat like that and putting it onto fluids? So about a third of cats that go into congestive heart failure, there is something that's happened in the veterinary clinic within the preceding 2 weeks that's triggered that heart failure. I guess that's really important to remember too. So about a third of all cats will have either had recent steroids, fluid therapy, or just a trip to the vets has been enough stress to tip them over the edge. So I think if we're thinking, well, we're going to check renal function before we do a dental, and we know that in the older cats the prevalence of HCM could be 29%. I'd ask you to question, if you're doing bloods for renal function, how often does it change what you do? How often do you find renal disease that you would manage under a GA? Thinking that actually a third of cats may have underlying heart disease, for me is like a big thing. And obviously I'm a biased advocate for looking at heart disease, so I completely put my hands up to that. But if we're going to sort of offer blood tests to look for renal function, should we be offering assessments of left atrial size? And my opinion is probably yes. I think we should be looking at left atrial size. I think that's probably more valuable than an NT-proBNP, and it gives you the information there and then. If you think about NT-proBNP, you have your SNAP tests, which are your qualitative tests, where you either get a positive or a negative. And you have your cage side test now as well. So in some places you can get a numerical value of cage side too. But a lot of the time, those values, to get the numerical value, is sent to an external lab. And you've got the time delay that comes with that too. And you have an immediate left atrial size to assess risk with your DA in those patients. So yeah, I think that it probably should be something to consider, or at least have a chat in your clinic about when you go off this webinar, to sort of see whether you should update any protocols. Slightly controversial.
Thought-provoking there.
Yeah.
Brilliant. Next question: has anyone linked coronavirus to transient HCM?
Yeah, another great question. So there's been some data during coronavirus where coronavirus has been isolated from the heart, and also from cats with evidence of respiratory distress as well. So can coronavirus is it a cause and effect? Are these cats just carrying portions of the virus and develop heart disease? Is unknown. But there's sort of an association, and there is a link, but whether it's causative association is unclear. When we think about the transient myocardial thickening, the paper that was published was pre-pandemic, pre-COVID pandemic, in case we have any more pandemics, and this goes out another time, but pre-COVID pandemic. And in that situation, that paper was published in 2018. So these cats are all pre-pandemic, before we knew about COVID. So potentially, yes, we know that viruses can cause myocardial edema. And we do wonder whether there is some form of an insulting agent that causes the transient myocardial thickening, but as yet undetermined.
Brilliant. I'm just going to almost circle back a bit to the last question, because it's set a few more questions coming through, which is great. We've started the fire in people. So if cats show no clinical signs of heart disease, how do we know to scan them initially? How can we justify this to the owners? Very true. It is a really difficult question to answer, but it is a really good question too. So the asymptomatic cat that comes in, I think when I have that conversation, I'm privileged in that these patients are being referred to me. So I appreciate that in practice, that's a much more difficult conversation to have. Whereas most of my clients will be coming to see me because they want to know whether the murmur is significant, or whether an arrhythmia or gallop is significant. I think if we don't have any outward signs of heart disease, it is a big undertaking to screen every single cat that comes in that is asymptomatic. And you start to go down a rabbit hole, because, yes, there is heart disease in populations, and I think kind of one of the keys is that 1 in 7 cats will have HCM, but is that statistic enough for us to be looking at doing screening? I think if we're thinking, should we be screening, if you're screening at geriatric cats, for example, and you have a geriatric cat screening clinic when they get to a certain age, then probably we should be assessing left atrial size in those cats as well. So if you have some form of screening clinic for your older cats, for sure, I think that we should consider it. Remember that in geriatric cats, the prevalence increases to almost 30% of the population. So I think for sure we should be considering it in that sort of setting. But it is a hard sell to an asymptomatic cat. And I think that it can also maybe be considered that that we are scaremongering if we start to say, well, there's this 15% chance your cat might have heart disease in its lifetime. But that is the reality. So, it unfortunately is the reality. And I think for me,
education is probably key. Just sort of what to keep an eye out for, knowing that it is an iceberg type disease, that, under the surface, there's a huge amount that could be going on that we just don't know about from the surface. But you could say that for every disease until it goes from being subclinical to clinical. You could say the same for every single disease. So my kind of suggestion on this is that, yes, let's treat the ones when we see clinical signs. Let's have the discussion with the owners. If we're doing screening clinics, let's consider like assessing left atrial size. But would I do it in every single patient that comes into general practice? I think that's probably unrealistic and an unfair expectation. But if you have a page on your website to sort of increase owners' awareness of heart disease, it gives them the information then to make their own informed decisions.
Brilliant. Next question. I've heard that furosemide should not be used in cases where pericardial effusion has been diagnosed or is suspected. God, I'm losing my words now. Suspected. Is this correct? If so, what is the reasoning behind this, please?
Yeah, so I think what we probably have to separate out of that question, because it's a really good question, is pericardial effusion and cardiac tamponade, and separate those two things out, because you can have fluid in your heart sac without the heart being squashed and compromised, or you could have a large volume pericardial effusion that is causing tamponade, so kind of squashing and diastolic collapse of your right heart and sometimes the left heart, which is sort of a much larger volume, causing like this really high intrapericardial pressure that exerts that force onto the heart and prevents the heart from being able to offload its output properly. And in that situation where you have significant tamponade, furosemide is contraindicated. And the reason is that if we reduce the preload, so if we reduce the circulating volume in these animals, well, there's less volume going to the heart. So the heart is going to kind of compact down. You make the animals worse by giving furosemide if there's evidence of tamponade. When we think about our cats, it's very rare that cats with a pericardial effusion will have cardiac tamponade. So it's rare that I would drain a pericardial effusion in a cat unless I thought it could represent some kind of neoplastic effusion. If there's no tamponade, we would treat these cats with furosemide, assuming that there's no tamponade. If the volume is large and there's no tamponade, we're still likely to tap that pericardial effusion. But low volume pericardial effusions, we would be quite comfortable to give those cats furosemide for what would be considered a congestive heart failure sign. So cats in heart failure, we think about sort of left-sided heart disease being more like pulmonary edema. But remember from our talk that we also will see right-sided heart failure type signs because of left-sided heart disease in cats. And that might manifest as pleural effusion, pericardial effusion, and sometimes ascites as well. So in that sort of complex, we wouldn't refrain from giving furosemide in the presence of a pericardial effusion in a cat, assuming that there's no tamponade. Great question.
Brilliant. And just on that same furosemide, what dosage would you start in CHF, and do you use butorphanol for sedation?
Yeah, I'm going to start with sedation, because actually I think it's so important for these cats in heart failure who are removed from their home environment, traveled in a car, not used to leaving home, arriving in a vet clinic, lots of barking dogs, smells of cats. It's like the worst place to be if you're in congestive heart failure and really struggling with your breathing. And I think the first thing is to try and offload any edema or pleural effusion kind of as quickly as you can, but not doing so quickly that you kind of cause the cat to be very compromised. Usually for our really sick cats, they'll come in, they'll go straight into oxygen. We'll give them 5 minutes or so to kind of try and relax. If we're not seeing any improvement over 5 minutes, we're often doing a cage side T-fast to assess, is there pleural effusion that needs draining immediately, and we're giving intramuscular furosemide at that stage as well. So when I think about the dose of the furosemide that goes in as the first dose, if they don't have an intravenous catheter, then I will give them 2 milligrams per kilo as an intramuscular injection, and I will then drain the pleural effusion if necessary, and then would be following that up quite regularly and quite frequently with top-up doses of furosemide sequentially. So my kind of typical plan for a cat is first dose IM or IV, 2 mg per kilo. An hour later, I'm giving another dose of furosemide, and that will be dependent on if we've seen any improvement in the respiratory rate or not. And that might be 2 mg per kilo or 1 mg per kilo, just dependent on whether we've seen any downward trends of respiratory rate. If there's pleural effusion, I drain that as soon as I can, and I feel the cat would cope with that. When we're thinking about drainage, I'll often give butorphanol for that and often maybe think about some alfaxalone as well, which is something we use here in the UK, to try and just keep the cats calm whilst we drain them. As soon as we start draining the infusion, the cat's respiratory rates often improve dramatically as well. When we're thinking about that frusemide down titration, often these cats that come in with really bad edema might be in the 60s, 80s, sometimes 100 when they arrive. They might just be open mouth breathing and panting. And so in all of those cases, we would give 2 mg per kilo on arrival, another 2 mg per kilo within the first hour. Then I'd be starting to reduce it to 1 mg per kilo every hour and waiting to see that respiratory rate come down. And once we're kind of seeing it coming down, so once I start to see it a downward trend, not necessarily that it's normalized, but once I start to see it coming down, I will start to increase the interval between each dose. So rather than being every hour, we might go to every 2. And if the respiratory rate continues to decline, every 4. And then if we're at every 4, then I'm often at the point thinking, well, actually the respiratory rate here is probably good enough. The cat's not so compromised that we can't start to medicate this cat orally. And we try and get the cats home as soon as we can. We know that trying to get a cat's respiratory rate in the clinic, certainly in our clinic, it may be different for you guys, but in our clinic, we won't expect the cat's respiratory rate to be normal when it goes home. I just want to see that they are responding, the respiratory rate is coming down, and don't necessarily wait for it to be less than 30 in the clinic. That's what we'd hope to see at home when the cats are nice and relaxed, but I would rarely expect to see it less than 40 in the clinic, and I'm comfortable to send the cats home with respiratory rates of in the 40s if they'd previously been up in the in the high sort of in the high 10, well, high double figures, I should say.
Great. We've got lots of questions still coming in, so how we fix the time?
I'm here all night. No, not really, but definitely we could take some more questions.
Okay, brilliant. I've got quite a big question here, so I'm going to read it all out, but we might, I'm happy to do bits of it because I think we might need to break it down. So how can you differentiate between end stage HCM that looks like DCM and RCM? And would pimabendin or ACE inhibitors be beneficial, or by the time the CHF is that's bad, furosemide and clopidogrel more important? Sorry, big questions.
Yeah, it's a great question. My first question, first kind of question back is, what will we do differently knowing whether it's an end stage HCM versus a DCM versus some of the others? I think probably what I would look at is probably more of the phenotypic changes. So if there is left ventricular systolic dysfunction, I would consider pimabendin. I think the benefit of ACE inhibitors at the moment is questionable for heart failure patients. So they aren't a drug that I would typically give to a heart failure patient. I think when we also think about that question, I think we've got to also consider the tablet burden, that many cats are outdoor cats, and also that we want to make sure that we maintain the pet owner bond as much as we can. So if we can, liquid form of medications often is much more well tolerated by cats, and I think owners perceive that it's easier to medicate the cats that way. I think that's very true. Certainly, if I tried to medicate my cats, I'd want to try and give as few drugs as possible, and give the ones that really matter. So if I was breaking it down in stage C cats, probably like a loop diuretic is the most important drug to keep the congestive heart failure back out of bay. Then an antithrombotic would be the next one. And if these cats present with hypotension and signs of poor forward output, then considering pimabendin as well. But I put the other 2 drugs, spironolactone and ACE inhibitors, a bit lower down on that list. If they'll be tolerated, if the cats are really easy to tablet, I don't think there's been any evidence that those drugs do harm, and there's potential benefit there as well. So I would not dismiss them completely, but that is a really important question for the owner. And I often send cats home just on furosemide and clopidogrel when they've had stage C disease, and may consider pimabendin, but usually only once I know the owners can medicate with furosemide and clopidogrel or rivaroxaban, as I consider those to be the key drugs to keep that cat as well asymptomatic as we can, or as subclinical as we can.
Brilliant. And just on the rivaroxaban, question here is, what's the dose rate for it?
Sure. So we are giving 2.5 milligrams once a day to cats with rivaroxaban, and that can go alongside the clopidogrel. Clopidogrel kind of indefinitely inactivates the platelet. So once it's given, that platelet is out of play for its whole lifespan. So we would give both together, but rivaroxaban 2.5 milligrams once a day.
Perfect. Do you have any thoughts on rapamycin?
I do. My biggest thought is that there is some huge potential there for reducing left ventricular hypertrophy and potentially improving outcomes. So my kind of thoughts are that it's a very exciting place at the moment in the veterinary world. I think we're going to see some great information come out on it, or at least I hope we will. Obviously, I don't know yet, but I really hope that we do. You know, when we think about HCM affecting 1 in 7 cats, it would be amazing to think that we have a drug that not only reduces hypertrophy but actually improves outcome. And I guess for me, that's always what I'm considering is it's great that we can improve the things that we can see. It's like the atenolol. It's great that atenolol reduces heart rate, reduces murmur grade, but if that doesn't translate to a clinical benefit for the patient, that's the information that I always want. That's the nugget of information. Has it been worthwhile that the owners have been medicating this cat every day for the rest of its life, or every week with rapamycin for the rest of its life, if there's no survival advantage? Are we just making our echo look better, but we're not actually giving the cat any benefit in the long term? And I guess that's what we need to know, and we don't know yet. But if I had a client, if we had it available and a client was keen to use it, I wouldn't say to them to avoid it. I think the data that's there would support that it may be beneficial. I don't know that we have enough data to say that it's not harmful. And I don't think there's any data to say that there's a survival benefit yet. So those are probably my thoughts. But at the same time, whilst I kind of have a bit of caution in what I'm saying, I'm actually very excited about it. And I hope that it provides an answer for a disease that we haven't been able to do very much for. And we just sort of manage the symptoms when they go into heart failure. It'd be great to think that we could delay heart failure by starting sort of treatments like mavacamten or rivaroxaban and the new novel agents that come after them as well. And I just really hope that translates into a survival benefit for the cats.
Brilliant. And I think your echo, there's a couple of people saying, thank you for a very comprehensive, interesting talk. Hope rapamycin pans out. So it's certainly been echoed by many out there. So let me just, what are your opinions on the use of cardiomarkers in cats?
So if I think of the two main ones that we're going to use, so NT-proBNP being one of them, cardiac troponin being the other. If we think of what their uses are for, so generally, if we think about NT-proBNP, it's an indicator of atrial stretch, sometimes ventricular stretch as well. So if you have stretch of your myocardium, you will see that the NT-proBNP is increased. When we think about troponin, troponin is leaked from cardiomyocytes that are damaged. So one is telling us about cardiomyocyte damage, the other is telling us about cardiac stretch. And the thoughts there really would be troponin has been shown to have some negative, some prognostic indication. NT-proBNP as well, and reductions in NT-proBNP have been shown to have some clinical relevance in terms of the expected outcomes for cats, or poor outcomes for cats. I think that when I think about what I'm doing for these cats, they're not things that I reach for on a regular basis. For me, if I was to have a high NT-proBNP, I'm going to probably want to echo that cat to confirm, do we need to start do we need to start an antithrombotic? So in my hands, I feel that that an NT-proBNP is not as valuable in terms of the information that I get from it for kind of subclinical heart disease. And I think if we're thinking about clinical heart disease, then there are tests that will give us the information that the NT-proBNP would give us, and much, much more. I think there's some studies that show that it can help to increase your confidence as a clinician. If you have a cat that presents to you and there's signs of respiratory distress, it's absolutely been shown to improve confidence in decision making on congestive heart failure and its management. I think troponin has a limited value in the most part as a primary tool. I think that the main reason that we look at troponin in most cases would be for patients where we're suspecting myocarditis. So I think that's sort of a much more challenging discussion for our listeners who are in places where they have snake bites, and you see kind of myocarditis secondary or myocardial damage from snake bites. Troponin could be very valuable to say how unhappy the heart muscle is, but I guess we know that it's going to be unhappy if you've had a snake bite, for example. And so what extra information does it give you? Probably in the acute phase, not a lot. But if it stays elevated, that probably be more concerning. So it's perhaps trends could be helpful for trends as well.
Fantastic. I've got two people asking the same question, so we'll bring that to you next. What is your opinion on furosemide CRI?
Yeah, we reach for frusemide CRIs if we feel that patients aren't responding well. My typical go-to is to use bolus dosing. So I will typically give bolus dosing to patients. Rather than a CRI, but there is great evidence for using CRIs as well. I think it sort of becomes a preference on what equipment you have available. So do you have syringe drivers that you can give frusemide titrated to kind of very small volumes for cats over time? And if you have those, then I think you've got an option to go for a CRI versus an injectable bolus form. I think that in terms of when we use the CRI, potentially might see more changes in electrolytes that way in using the CRI. And I don't think there's any evidence that those cases are more quickly discharged or have a better outcome from managing heart failure. So I think that both are valid. And I think if you work in a very busy ER clinic where you think, actually, I'm going to struggle to get back to this cat on a regular basis. If you're a single sole person and you go into theatre with your team, it may be that you having a CRI means that cat's consistently getting medication. If you have a busy ER, both options are valid.
Fantastic. We've got quite a few more questions coming in, so I think we might start to round this off if that's okay.
Sure.
And what I might do is just send some of these over to you and form a little document of some of the remaining questions, if that's all right, if you're all right to type some of these up, and I'll go through some of them as well, because they're coming in thick and fast. There's so much interest here, which is absolutely fantastic. I do have to do a shout out to our Australian Robert Williams. He has made sure that the Australians have got a mention. So there we go, Robert Williams. Well done. Thank you for joining us tonight all the way from Australia. It's lovely to have you with us. We've had some really, really great feedback, Chris. Just a fantastic talk, really interesting. People are just sending in really lovely messages. So thought I'd share that with you, that it's certainly gone down really well, been fantastic. So to everybody else out there, I am going to send around your certificates shortly. We'll do a quick redirect. And there has been another question, will this webinar be recorded? Yes, everything's been recorded, including this question and answer session. So we'll be able to, I'll sit up for a bit longer, might go and get a glass of wine. And then I'm going to create the on demand for you so that you'll be able to view that pretty much straight away as soon as I've done that. It takes about an hour to generate. For anybody watching this webinar on demand, you can get your certificate by hitting the check my scores button when you come out of the video screen. You can see that there, or you can always pop us an email at Bova. So it's office@bova.co.uk. And one of my team members or myself will reply back to you with your certificate. So please don't hesitate to ask us for that. So thank you, Chris, once again. This has just been an absolute pleasure to have you on board tonight. And I hope you enjoy the rest of your evening, and good luck with your new venture, if I can say that. So
Thank you very much.
So I'm going to do the redirect quickly, if you just all bear with me. And hopefully this works. Okay, that should have gone out to everybody now. So I will stop the broadcast. If that has epically failed, then I will get that certificate out to you. So don't you worry. Thank you and good night.
Good night.